طيب بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله. الزملاء والزميلات الأعزاء، مرحبا بكم في الحلقة الثالثة من برنامج سابا for Internal Medicine Review. ضيفنا الليلة دكتور خضر دلوك, cardiac electrophysiologist. Today we're going to discuss إن شاء الله EKG one-on-one. EKG can be a very intimidating topic for physicians in training and junior physicians. And today, Dr. Khidir will help us shed light on the fundamentals and how to approach EKG. Please feel free to join us on our Facebook page, YouTube channel, which will have the recording after the session, and our Telegram channel that we will share in the link below. I would hand it off to you, Dr. Khidir. Go ahead.
شكرا مازن. السلام عليكم. في البداية عاوز بس أشكر SAPA والinternal medicine chapter يعني for leading these teaching sessions, and for Mazin and the rest of the team يعني for giving me this opportunity to talk today about basics of ECG. ال ECG زي ما قال مازن can be very intimidating. أنا لما طلعت من السودان ما كنت بعرف أقرأ ECGs. I think part of it إنه الميديكال سكولز بتاعتنا ما بتدرسنا ال ECGs أثناء الميديكال سكول، وبرضه بعد ما نطلع على الهاوسمانشيب برضه ما بنشوف ECGs كثيرة. Here in the US and all around the world, every patient gets an ECG. يعني practice makes better. If you don't see an ECG, you're not going to know how to read it. So I think part of our problem يعني back في السودان إنه ما قاعدين ناخذ ال ECG أثناء الدراسة، وبعد ذاك ما بنشوفها كثيرة أثناء البراكتس. لكن maybe things are changing now. يعني الناس في السودان هسه بدأت يكون في a lot of ECGs being done. So إن شاء الله hopefully الليلة يعني نعرف some of the fundamental and basic concepts about ECG. هو هيكون talk يعني mainly basic talk. Some of you might already يعني know how to read an ECG. Some of you might be experts, but maybe learning a few bits and pieces will add to your knowledge. I don't have any conflicts of interest to disclose, or no financial relationships. The objective of our talk today is to give you a background history about the history of electrophysiology and electrocardiography and the genesis of the ECG waves, and to build up a systematic approach of how to read an ECG and have a basic understanding of some basic ECG abnormalities. There is a lot of books, you know, that you can read about ECGs. You know, just choose the book that you feel more comfortable reading and easy language for you to understand. You know, I have a lot of slides from the ABC of clinical electrocardiography and the portable ECG interpretation. A lot of the medical school students here in the US use rapid interpretation of ECGs by Dale Dubin. I just put it there as a source. لكن زي ما قلت you can choose any ECG book you know to read. في البداية عاوز أتكلم عن historical overview يعني of electrocardiography and the waves of the ECG. The start of electrocardiography and electrophysiology started with the discovery of the anatomical structures of the conduction system. As you can see in this figure, the first to be discovered was Purkinje fibers by Dr. Purkinje, who was an anatomist from the Czech Republic or Poland, you know, others say from Poland, in 1845. In 1893, Dr. Wilhelm Hess, he's a German physician and anatomist, discovered you know, the Hess bundle and the AV node. Ashoff and Tawara discovered the AV node between 1893 and 1906, and Arthur Keith, who's a British anatomist, discovered the sinoatrial node in 1907. You can see that we have different nationalities. It's almost like a United Nations discovering, you know, the conduction system of the heart. At that time, people, of course, did not have easy communication, like, you know, text messaging and internet. Some of them were working and discovered, you know, one anatomical structure while people in the other side of the world were discovering the same thing. And they were just mainly collaborating, of course, by publications and letters at that time. But the era of cardiac electrophysiology and electrocardiography started by the discovery of those important anatomical structures. The other thing that advanced the field was the discovery of how to record bioelectrical recordings. On the left side, you can see this is Gabriel Lippmann. He is a physicist. He was born in Luxembourg, and his parents were French, so he moved to France, where he, started to be interested to be a teacher. He actually failed his exam and decided to be, a physicist. So he was actually sent by the French government to Germany to study at the University of Heidelberg, where he invented his capillary electrometer that you see on the right side of the screen. It was mainly made of a capillary tube filled of mercury and sulfuric acid. And, he used a magnifying glass to look at the meniscus between the, mercury and the sulfuric acid, and, had a photograph and used those aluminum wires to record, to attach it to the surface of the skin so that he can record electrical potentials. And this was the first primitive sort of ECG that was invented by him. He later on won the Nobel Prize for his work in color photography, and the phenomena of interference. The first ECG was recorded by Augustus Waller. He was a British physiologist who used the Lippmann capillary electrometer to record ECGs. And as you can see, he recorded a couple of waves. They were mainly ventricular waves at that time, and he called them V1 and V2. He was a physiologist, and he noted that these waves are coming from the ventricle, so he named them V1 and V2. Einthoven, of course, is well known. He got his Nobel Prize in 1924 for the work that he did in the field of electrocardiography. Wellen was a Dutch. He was born actually in what is known now as Indonesia. His father died when he was 6. He moved back to the Netherlands, where he was raised up by his mother, went to medical school in the Netherlands, and later on, he became very interested in electrocardiography. At the beginning of his career, he was actually did a lot of work, in the vagus nerve and its relationship to his respiratory system. But then he, at some point, he went to Switzerland to attend an international conference where he saw the capillary electrometer of Lippmann and how it can record the ECG, and he was very interested in recording electrocardiography and electrical signals from their end. In the Journal of Medicine, there is a nice story. This was from 1971. It refers to this guy called René Descartes. He was actually the father of modern philosophy. He is a mathematician as well. He invented the geometry and the Cartesian system. The X and the Y axis that we see now is invented by this guy. He is French, but he spent most of his time actually in the Netherlands. And he studied a lot of optics as well. And this was at the time of the scientific revolution back in the 16th and the 17th century. This is the era that started our modern, science and, belief in physics, math, and those kind of scientific studies. He published his first paper called The Geometry or La Géométrie in 1637. And as you can see in the figures that I'm going to show here, he studied optics, and he used to, point his dots in the semicircle or the figures that he draws by an O or a C as the center of the circle or the origin of the circle, and in the periphery by P, QRSs, and Ts. So he was the first one to, in geometry to allow us to represent numbers by alphabets. And those depictions, I think, were studied by Eindhoven. Eindhoven, of course, as I mentioned, studied his medicine in the Netherlands, and he studied the work of Descartes. Eindhoven, when he used the electrometer, the Lippmann electrometer, he was able to get similar waves, just like Waller. He was able to get the two ventricular waveforms, and he named them A and B. He did a mathematical correction to the formula to allow for friction in that capillary electrometer, and then he was able to identify 4 more waves, and he named the waves A, B, C, and D, as you see here, if you can see my cursor. Later on, he figured out that the electrical or the capillary electrometer was not the best way to record the heart, and he came to know about the string galvanometer, and at that time then he was able to record the ECG as we see it today. And since he already named his waves A, B, C, and D, this is why he chose the letters P, Q, R, S, and T. So if somebody asks you why in an ECG, the alphabets are P, Q, R, S, and T and not A, B, C, D, this is a good story to mention. Others say that he chose those letters in the middle of the alphabet so that if he discovered other waves, he can add them to the right and the left of those alphabets. So this is a nice story. This is the Eindhoven string galvanometer. I'm showing you here, this is one of his first recordings in 1920 of the ECG. He only used lead 1, and you can see that there is P, Q, R, S, and T as we see it today on our ECG. And this is the first ECG machine. You can see how huge it is. And you can compare it to the ECG machine now. These ECG machines are actually galvanometers. They're, our technology and the advancement in technology allowed us to advance a lot in the medical field as well. And now you can actually do your ECG in your hand by even using your iPhone. So what is the ECG actually measuring? The ECG actually, if we take it at a cellular level, it is a measure of the action potential. The action potential, was discovered by an Italian physician, decades ago. And as you can see, in this cartoon, it shows the 5 phases of the action potential. Phase 0, which is the depolarization phase. Phase 1 and 2, which are the plateau phase, and then phase 3, which is the rapid depolarization, and phase 4 is the resting state. This is a nice diagram from Frank Netter's book. It depicts the action potential, and it as well shows you a myocardial cell. You can see, this is the inside of the cell, this is the outside of the cell, and here they have electrodes, one inside and one outside, and it measures the potential difference or the voltage difference across the cell. Here you can see that potassium is predominantly inside the cell, sodium is predominantly outside. In phase 0 of the action potential, you can see that a lot of sodium gets into the cell. This will bring the action potential from -90, which is the resting potential, more positive, getting inside the cell till it goes all the way up to +20. And this is what causes the depolarization phase at the cellular level. As the cell depolarize, then you will have this plateau phase, an entrance of sodium into the cell, and the exchange between sodium and potassium sort of holds up. Not a lot of exchange happens. Calcium as well helps the plateau phase to stay around the 0 before the rapid depolarization phase happens because of potassium going out of the cell. To help the cell comes back to the resting stage, you have the sodium ATPase pump, as you can see it here, that brings back potassium inside the cell and gets sodium pumped out of the cell. So at the cellular level, this is what the ECG is looking for. If you do a voltage sort of depiction or graph of voltage per unit time, you will see the action potential as you see it here. At a macro level, the ECG, of course, combines all those different cardiac cells. And it's a very well orchestrated group of cells that beat in harmony, and the summation of those action potentials, if you will be summated as the as the EKG as we see it now. As you see here, this is an anatomical structure of the sinus node, the different channels within the atria that allows conduction, rapid conduction within the atria, the Bachmann bundle that allows conduction to go to the left atrium, the AV node, and then the His, as well as the different bundles. You can see their different action potentials as it is depicted in the cartoon. And you can see that, the summation of all those forces together is color-coded in the ECG at the bottom. It's very important to have, if you're to have a good understanding of the ECG, excuse me, you have to have a good understanding of anatomy, you have to have a good understanding of electrophysiology as well, or physiology, of the cardiac myocyte to get an understanding of, of the ECG. As you can see here, those action potentials, phase 0 of the action potential is actually what causes our QRS, and phase 3 mainly is what gives us the T wave. So, you can see here based on different channels and, at a molecular level going sodium in, potassium out. This is what gives the action potential. And as a summation of those cells being put together, you get the ECG as we recorded. Any questions so far?
So far, Dr. Khidir, nothing major. Only one question from Lubna was about apps, phone apps in assisting in reading EKGs.
You can use phone apps. They might help you. I mean, there are even EP apps that can help us in EP to do different kinds of things. But I think in order for you to be able to learn how to read an ECG, you should do it yourself. You should not get the app to read it for you. The app, these are, programs that can help. Now the use of artificial intelligence is being used in everything, but I think you should read your ECG yourself, because the ECG that you're going to be using in your emergency room or in your hospital is something that, you can read. You can scan it, of course, and get the app to read it. But I think what I would recommend is to have a systematic way of reading the ECG so that you can be good at it. And the more you read, the more you're going to be good at reading ECGs. So I'll proceed. As you know, we have 10 electrodes that we put, different parts of the body so that we can record our 12-lead ECG. You can see it here that we have limp leads, and these are called bipolar leads because they measure a potential difference between, the left arm and the right arm. The left arm being the negative pole, the right being the positive. Or actually vice versa, sorry. The right is the negative pole and the left is the negative pole. So the electrical difference between that will give you lead 1. The electrical or the voltage difference between the right arm and the left leg will give you lead 2. And between the left arm and the left leg will give you lead 3. These at the bottom here are called augmented leads. And these are as well unipolar leads. They are called augmented because as you can see here, just the electrical wiring is to augment the amplitude of the QRSs that they produce. That's why they're called augmented, and that's why you see AVR stands for augmented vector, and this is from the right arm. You can see that there is usually a reference point, and the positive electrode is going to be on the right arm in this case. In the left arm, your positive electrode is on the left arm, of course, and then the left leg is what gives you lead AVF from that null point or that central point. That central point, does not have a zero sort of electrical activity or voltage, but that electrical voltage does not change with cardiac activity. That's why it's referred to as a 0 point or a null point. The same concept is here in the precordial leads. Precordial leads are from V1 to V6. There is this central point which does not have changes in its voltage during electrical activity, and it compares the voltage between that central point and any of those leads from V1 to V6. These are as well called unipolar leads. So the only bipolar leads you have are the limp leads. This is the Eindhoven triangle. So when Eindhoven started recording ECGs, he mainly had lead 1, lead 2, and lead 3. And, they were equidistant from each other, and the heart was the central point. So he made up his triangle, and the triangle is mainly to allow you to depict the electrical axis of the heart. As you can see, this is the augmented lead. One more slide on the augmented leads. But I wanted to show you this slide here that shows you there is a horizontal axis of the electrical wavefront. Think about the electricity of the heart as if it's a wave. It's a wave of electricity that starts in the sinus node and then moves towards the atria and then to the ventricles. So that wavefront of electrical activity has an axis on the horizontal plane, which you can see through V1 to V6. This is your horizontal plane. And then you have a frontal plane, which is the plane that you can look at those limp leads to identify what is your wavefront doing in that frontal axis. The figure on the right side will show you that the blue is cutting the heart in the frontal axis. Horizontal axis is cutting the heart in the red, and then there is a sagittal axis. But we mainly use frontal and horizontal axes to determine the activation wavefront, how it's going in the heart. Another useful thing to understand is to have a three-dimensional image of how the heart is lying in the body, and what is the relationship of the leads to the heart. As you can see in this cartoon, leads AVL, lead 1, V5, and V6, they look at the heart from the lateral wall. So if you think about those leads as cameras taking pictures of the lateral walls of the heart, you will be able to see how is the activation wavefront coming to those leads. Similarly, from V1 to V4, these are anterior leads, and you can take a camera or a picture from those leads to see how is the wavefront coming towards those leads. And lead 2, 3, and AVF are the inferior leads. So keep that in mind, keep that picture in your head as you're thinking about how the activation wavefront is coming to each of those leads. An important concept to understand, and to keep in mind, if you're going towards a lead, this makes your potentials become positive. The QRS complexes or the P waves, they're going to be positive if you're going towards a lead. If you're going away from the lead, they're going to be negative. This video will show the activation wavefront. I just wanted to show you that we think about the electrical activity as a wavefront that goes through the heart. And you're going towards a lead or you're going away from a lead as this activation wavefront spreads from the sinus node to the rest of the heart. The sinus node is a group of cells that starts the electrical activity because they have pacemaking properties. They have the ability to depolarize themselves and start the electrical spark, if you will, and then the activation wavefront spreads from there to the rest of the heart. A general rule as well of the heart is whoever is faster will take charge of the heart. That's why we refer to normal rhythm as normal sinus rhythm, meaning that the rhythm is originating from the sinus node. Okay, the ECG is basically as I mentioned earlier, it's a voltage recording graph per unit time. So you can see that the ECG travels at a speed of 25 millimeter per second, it's calibrated in a way that each upstroke or each one amp of amplitude is equivalent to 10 millimeter of distance. And you know, in this ECG grid here, you can see that, you know, the ECG is made up of large boxes and small boxes. The small box is 1 millimeter in terms of distance, or 0.1 millivolts. And in terms of time, it's 0.04 seconds or 40 milliseconds. As you know, 1 second is equal to 100 milliseconds. So that gives you the 0.4. And each 5 of those small boxes make one large, you know, box. And one large box is 0.2 milliseconds and 5 millimeter and 0.5 millivolts. So these are important things to keep in mind when you're making your calculations, and when we're, you know, getting to understand how do we get the heart rate from the ECG. These are important things to remember. Here it shows you different amplitudes in terms of how tall, you know, these QRS complexes are. There is a lot of factors that can cause why the QRS would be, you know, tall. This, you know, depends on the position of the heart in the body. It depends on the chamber size. It depends on, you know, the ventricular muscle. Is there left ventricular hypertrophy or not? So all of these contribute to the, you know, how tall those waves are. An important thing to notice is that this is the standard way of ECG recording, 10 millimeter per volt, as we show it here, 10 millimeter per millivolt. So always make sure that your ECG is standardized, because if the gain is different, then you're going to be falsely reading things in the ECG that are not there. Any questions so far?
So far, so good, Dr. Khidir.
Okay.
So if there is any questions, guys, we can use the Q&A section. I see there is a hand up, but we had previous technical difficulties. So let's utilize the chat or the Q&A session, and we will answer your questions.
Okay, great. So let's move on forward. This is another important concept that I want you to, you know, to understand and keep in mind. As I said, the shape of the QRS, or even the shape of the P wave that we record in the ECG in any of the lead depend on the orientation of that lead and the vector of depolarization, that wavefront. If this wavefront is going through this lead, if you think about this is your lead, or this is your camera, and the wavefront is coming to it, if you're going towards a lead, your deflection is going to be positive. If you're going away from a lead, you know, this wavefront is going this way, so it's going away from this lead, that's why it's negative. If the wavefront is traversing those leads, as you can see, those leads, the wavefront is going, bypassing them, you can see that the wavefront or the amplitude is equidistant or equiphasic. You know, there is a positive and a negative deflection to it. And if the wavefront is perpendicular to a lead, you know, the ups and downs are going to be equal to each other. And here, you know, the R and the S will be equal to each other. And this is important, you know, in electrocardiography, in electrophysiology, because this is how we decide where is an activation wavefront is originating from. You can actually localize where, you know, this rhythm is coming from. You can localize where a PVC is coming from. You can localize where an accessory pathway is based on that concept. You know, where are things going in terms of their relationship to the different leads in the heart, and keep that 3D diagram there to help you identify, you know, your 3D image in your mind. You know, you can see that usually activation wavefront starts in the sinus node. You have to remember your anatomy. Where is the sinus node located? It's located in the junction between the SVC and the right atrial wall. And then propagation or activation wavefront spread to the atria, both before it goes down. This is the base of the heart, and this is the apex of the heart, of course. V1 to V6, they wrap around the apex. And this is an important concept as well to remember, combining anatomy and the location of leads so that you can, you know, understand why this lead is positive, why this lead is negative, why this is up, why this is down. you can see AVR is all the way up here. So any activation wavefront starting from the sinus node going away from that lead is going to make it negative. So that's why in every ECG, always AVR is negative. If you see AVR being positive, it's either that this is a lead misplacement or this rhythm is originating from a different area rather than the sinus node. As I mentioned, V1 to V6 wrap around the apex, and as the activation wavefront go from V1 to V6, you notice that the R wave gets taller, and the S wave disappears. This is called an R wave, and this is an S. And by lead 3, usually you should develop a 1 millimeter type of an R wave. Usually if you don't develop that by V3, this is what we call poor R wave progression. But as you see, as you go from V1 to V6, that R wave gets taller and taller. In order to efficiently be able to read an ECG, you have to have a systematic approach. If you read things systematically, you're not going to miss anything on your ECG. And sometimes the ECG can be very difficult, and it's very humbling even to us in the field of electrophysiology. Sometimes we come around ECGs that are difficult to read, and we basically go systematically and try to describe what we see. If there is any questions, I'm happy to take them before we continue, Mazin.
So far,
right.
Dr. Khidir, there have been no more questions.
Okay, no more questions. So in order to read an ECG, make sure that you have a systematic way. And these are things that can help, checking what is the rate, what is the rhythm, what is the axis, what are the intervals that we measure, is there any chamber hypertrophy, and are there any ST changes to suggest is there an infarction, whether it's acute or chronic. So these are 6 things that you can continue to look at in order to be very systematic in reading your ECGs. So in terms of the rate, as we mentioned, it's very important to remember that the ECG paper speed is running at 25 millimeter per second. And 1 large square is equivalent to 0.2 seconds, and and there are 5 large squares per second and 300 per minute. And this is where this 300 rule comes. The simple rule is to count the number of QRSs, and 300 divided by the number of large boxes in between those QRSs will give you the heart rate. And it's just simple math. If the ECG is running at 25 millimeter per second, and there are 5 large boxes in 25 millimeter, because 1 large box is 5 millimeter. So if you do the math, you want to know what is the heart rate in beats per minute. And 1 minute is 60 seconds. So if you multiply 60 by 5, this is how you get your 300 large boxes. And this is why we say 300 divided by the number of large boxes between the QRSs will give you your heart rate per minute. This is useful when the heart rate is regular. If the heart rate is irregular, sometimes that can be tricky. As you can see in this example, for example, you don't have all of them large boxes. You can see here there is 3 small boxes. So how can you do this? The other way to do this is to go by milliseconds. So if you go by milliseconds, the number for each large box is 200 milliseconds, right? 0.2 seconds is 200 milliseconds. So if you count by milliseconds, small boxes are 40. So you can count all that RR interval in milliseconds. And if you do 60,000 divided by the distance or the interval between those 2 RR intervals, as you see here, 60, this is how you get the 60,000 milliseconds. 1 minute is 60,000 milliseconds. If you divide that interval by milliseconds, this is how you get the heart rate in beats per minute. In occasions when the heart rate is irregular, the 300 rule might not count. But as you know, the ECG is running in, the whole ECG paper is 10 seconds. So one thing you can do is to count the number of QRSs in this 10-second strip. So if you count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, and multiply 12, you know, because this is in 10 seconds and you want it in 60 seconds. So if you multiply that by 6, you will get your, you know, your rate per minute in an irregular heartbeat. Questions in that part? No questions. All right, so we'll move to the next part, which is the rhythm. In order to determine what is the rhythm, it's important to, you know, see, do you see discrete P waves or not? Is the rhythm fast or slow? You know, fast, of course, is more than 100 beats per minute. Slow is less than 60. Is the rhythm narrow or wide? Narrow and wide is defined by the width of the QRS. If the QRS is more than 120 milliseconds, this is by definition a wide QRS. If it's less than that, it's narrow. And then is the rhythm regular or irregular? You know, in this ECG here, you can see that this is very rapid. And if you just imagine that the RRs are one large box, if you divide, you know, or maybe this is more, of course, you know, let's say 2 boxes, this is going to be 150. 300 divided by 2 large boxes is going to be 150 beats per minute. But I think it's faster than that. And it's narrow. The QRSs are narrow. So by, you know, by just describing what you see, I don't think I see discrete P waves. The rhythm is fast, it's narrow, and it's regular. So this is a narrow, complex tachycardia. In order to determine what the rhythm is, you know, as we said, you need to define whether you see P waves or not. And the best leads to see P waves are lead 2 and lead V1. And the other part is to identify the relationship between the P and the QRSs. You know, the P, as you know, is because of atrial depolarization. We do not see atrial repolarization on the ECG because by that time, the QRS, you know, or the ventricles would have contracted and their electrical depolarization is much, you know, bigger in magnitude. That's why we don't see the, you know, atrial repolarization. But at least the P wave signifies atrial depolarization, and we best see it in lead 2 and V1. The cardinal features to say the rhythm is originating from the sinus node is to look at the P waves and make sure, are they upright in lead 1, 2, 3 AVF, and whether they are biphasic in lead V1. The other part that people always focus on is there a P behind every QRS. A P behind every QRS does not necessarily mean sinus rhythm. P behind every QRS or one-to-one relationship between P and QRS tell you the relationship between what, you know, the atria and the ventricles are doing. They are in a one-to-one relationship. But, you know, in order to say this is sinus rhythm, as you see on the video, rhythm originates from the sinus node, it's up. So why is the P wave upright in the inferior leads? Why is it upright in lead 1? As I mentioned, you know, earlier, in order to, you know, determine why would a deflection be up, positive or negative, it depends on if the activation wavefront is going towards the inferior leads, you know, because the inferior leads, if you imagine them, they're at the bottom looking at the inferior of the heart, the activation wavefront is going towards lead 2, 3, and AVF, as well as lead 1. That's why they are always positive. You can see lead 1 is positive, lead 2 is positive here. And in V1, most of the time, you know, the P wave is biphasic. You know, it has a positive initial deflection and a negative deflection at the end. And the reason that is because the sinus node is at the, you know, in the right atrium, between the junction of the SVC and the right atrium. Lead V1 is an anterior lead. So if you imagine the activation wavefront going towards lead V1, this will get you the initial positive deflection in V1. But anatomically, the left atrium is a posterior structure. So once the activation wavefront starts spreading to activate the left atrium, all activation wavefront is going away from V1, and that's why you get the negative deflection in V2, the negative deflection on the second half. So as you can see it here, The first part is positive, the second part is negative, and then you can say that this is sinus rhythm. Sinus rhythm is upright P waves in lead 1, inferior leads, biphasic in V1. P-QRS relationship will tell you the relationship between top and bottom. As I mentioned, it's not necessarily sinus if every P is followed by a QRS. This is an example of sinus rhythm as you see it here. P waves are upright in 1, inferior leads, and biphasic in V1. Here, this is an example for you. As you can see here, there is a P followed by a QRS and a T, and the sequence is 1 to 1, but this is not sinus rhythm. Can somebody tell me where is this coming from? Where is this rhythm originating from? It's not originating from the sinus node because the inferior leads, you can see the P waves are negative. They're inverted. The sinus node, as you saw it on the cartoon and the video, the sinus node is all the way up there and you're going towards the inferior leads, you have to be positive. If this focus is coming from lower in the atria and going away from the inferior leads, this is when you get a negative P wave. So this ECG here is an ectopic atrial rhythm, and most likely it's low in the atrium, and that's why the P's are negative. And you can see here, V1 has only a positive deflection. You can even tell from here that this, being only positive in V1, that this is actually coming from the right atrium. This is another example. You can see here that lead actually 3, the inferior leads are positive. Lead V1 is predominantly negative, but as you can see here in lead 1 and AVF, the P wave is negative. So this rhythm is actually not sinus rhythm because sinus rhythm should not give you an inverted P wave in 1 and AVL. All right. Anyone can tell me what this rhythm is? So if we go systematically, we said you want to go by rate. And what is the rate on this ECG? If you do 300 by the distance between those RR intervals, this will tell you the rate. Is it regular or irregular? To my eye, this is regular. In electrophysiology, we use calipers to mark out if things are regular or irregular. You can use a piece of paper and just put dots and see if they march through, and that will tell you if it's regular or not. And I do not see any discrete P waves. So this is a fast, narrow complex tachycardia. Okay, and most of the time when we refer to fast, narrow complex tachycardia, the rhythm, we generally call it an SVT, supraventricular tachycardia. Okay, so the next thing that you, in our systematic things that we go through is the axis. And axis, as I mentioned earlier, it refers to the activation wavefront, in the horizontal plane and on the frontal plane. Frontal plane, is the one downwards. You mainly look at the, limb leads. Horizontal plane is mainly, you look at leads from V1 to V6. As you can see, this is the hexaaxial, diagram. This is made by, the Eindhoven triangle. You can see this is lead 1. If you draw a line from lead 1 all the way, lead 2 all the way back, lead 3, it will give you this circle which is broken into small pies. Normal axis is anywhere between 90 to minus 30 degrees. Left axis is here. This is called northwest axis, and this is right axis on this side. So normal axis is, is anywhere between 90 to minus 30 degrees. So how to determine that, and why is axis important? Because it can tell us, if activation wavefront is normal or not. It can tell us about pathology in the heart. Horizontal axis will tell us if, the rhythm is originating from the normal conduction system or not. So this is why axis is important. And always imagine the heart, in 3D, and, whether the heart activation wavefront on the frontal plane, how is it going and how is it going on the horizontal plane. A simple way is, on the frontal plane is to look at the limb leads. These are your limb leads. and you want to look at the lead where you have an equiphasic QRS. So this is QRS axis. I'm talking about QRS axis. Of course, the P wave has an axis, the QRS has an axis, the ST has an axis, and the T wave have an axis. Most of the time we talk about QRS axis when when we're referring to axis, but each of the waves of the ECG has an axis to it. If you look at the equiphasic lead, and why we're interested in equiphasic lead, because I mentioned earlier, if the wavefront is going perpendicular to a lead, if you imagine this is your lead and you're going perpendicular, that wavefront is going perpendicular to it, that lead is going to have an equiphasic QRS. So here in this example, lead 2 is equiphasic. So this is our lead 2, right? And if the wavefront is going perpendicular to it, at right angle to it, so if you imagine a right angle here, this wavefront might be going here, or if you make a 90 degrees from lead 1 this way, it could be going towards 150, right? It can either be going towards, the minus 30 or the AVL, or it could be going through the 150. If you imagine this is lead 2 and this is 90 degrees to it, okay? How can I determine the axis? Then you look at the other leads. Look at lead AVF, and lead AVF here, is negative. If AVF is negative, that is telling you that this activation wavefront is going away from lead AVL. It's not going towards it. If the activation wavefront is going towards AVL, AVL should be positive. This is the general rule here. If you're going towards the lead, you're positive. If you're going away from the lead, you're negative. And in this case, you can see that, it's more, where am I lost there? Actually, in AVL, this is positive. Sorry, guys. In AVL, as you see here, AVL, actually is positive. So that's telling you that the activation wavefront is going towards AVL. And it's going away from AVF and lead 3, because if it's going away from them, it's going to be negative. If it's going towards AVL, it's positive. So that's telling you that, this axis is close to minus 30 degrees or even beyond it, and this is left axis deviation. There is a simple rule to axis deviation. This is the pie chart divided here as normal, telling you this is between 90 and minus 30. So it's mainly between lead 1 and AVF. And why do we choose 1 and AVF? Because 1 and AVF, 1 is here and AVF is here, and that covers predominant part of normal axis. So that's why we choose 1 and AVF as our leads to pick. If your normal axis, both of them will be positive, right? Because you're going towards AVF, you're going towards lead 1, you're still going to be in normal axis. If AVF is negative, you're going away from, this is AVF is, if you're going away from it, this side, this is where your left axis is, as you see it here on this part of the pie. If your activation wavefront is going through this direction, you're going to be negative in AVF. If lead 1 is positive, if lead 1 is negative, as you can see here, if lead 1 is negative, that means that the activation wavefront is not going towards lead 1, it's going away from it. And as you see here, that means that the wavefront is on this side, it's going towards the right side. Axis can be sometimes a bit difficult to conceive, but if you just keep that in mind, how the activation wavefront is going towards leads, that's important. Make sure that you understand that the wavefront, when it's perpendicular to a lead, that lead is going to be equiphasic, and that will help you determine where is this wavefront going towards. Okay, questions?
I see a hand raised. Ibrahim, would you like to utilize the chat or Q&A function? You may
say that again, Mazin.
I said I see a hand raised, so we're going to ask our attendees to utilize the chat and Q&A function to make it easier for everybody to follow through. And I think Dr. Khidir, you may proceed, and we will pick up the question in the next step.
Okay. طيب, as we said, the axis deviation is important لأنه بورينا pathology, and there is a differential diagnosis, of course, for each of the axis deviation. Left axis can be caused by inferior infarct, by pre-excitation, by COPD, left anterior fascicular block. So it will just give you a differential. As you know, the ECG is one of the fundamental tools. It's a diagnostic tool that you can use to help you identify different pathologies. And this is just an example of left axis deviation. The wavefront, instead of going towards the normal zone, the wavefront is going up here towards the left axis zone, and that's why we call it left axis. This is an example of left axis deviation. You can see here that if you just use the simple rule of lead 1 and AVF, if they're both positive, that's normal. If lead AVF is negative, then that's left axis deviation. If lead 1 is negative, then this is right axis deviation. Right axis deviation can be caused by a lateral infarct, left posterior fascicular block, ventricular pre-excitation, and RVH. This is an example where the axis is going towards the right side. And this is an ECG that is showing that you're going away from lead 1, positive in AVF. This is a right axis ECG, okay? Next, we will go to intervals. I see that there is a question.
There is a question: from which point should we read the axis?
From which point should we read the axis?
Yes.
As I said, a simple way to look at the axis is just to look at lead 1 and AVF, okay? So if you don't want to worry about getting the degrees and all that, this is it takes a lot of time, and you need to define what is the phasic lead, and to go back and remember this hexagonal diagram. You can keep it simple. If you remember this, that's all you need. 1 and AVF. Normally they should be both positive, okay? In normal axis deviation, lead 1 is here, lead AVF is here. So if the activation wavefront is going to lead 1, it's going to be positive. If it's going toward AVF, it's still going to be positive, right? So positive, positive, this is normal axis, all right? Left axis, lead AVF will be negative, meaning that the activation wavefront is going here, this way, in this part of this, pi. If the activation wavefront is going this way, it's going away from lead AVF. That's why AVF is negative, okay? So a negative AVF is left axis deviation, meaning that the activation wavefront is going this way, away from lead AVF. In right axis deviation, lead 1 is here, right? This is lead 1. If you're going away from lead 1, that means that the activation wavefront is going somewhere on this direction. And that's why this is right axis deviation. So this is just the simple way of defining the axis if you don't want to worry about the degrees. I'm going to move towards intervals. So the PR interval defines activation of the atria and propagation through the AV node. And it is measured from the beginning of the P wave to the beginning of the Q wave, and that interval is called the PR interval. A normal PR interval is anywhere between 3 small boxes, between 80 to 120, between 2 to 3 small boxes, and anything more than a large box is considered as prolonged PR interval. The QRS duration between the initial part of the Q till the terminal portion of the S, normal is anywhere between 80 to 110. Between 110 to 120, we call it intraventricular conduction delay. Anything more than 120, we call it a wide QRS. QT is from the beginning of the Q to the terminal portion of the T, and that is that depicts depolarization of the ventricle. QRS is ventricular depolarization. QT is depolarization. And I will show you in a second here the intervals of the QT. So the normal PR we said is anywhere between 120 to 200, between 3 small to a large box. And if anything larger than a box, then you have prolonged AV delay. QRS is between 2 to 3 boxes. Different books will tell you different things. Sometimes they will tell you this is between 80 to 110. As I mentioned, between 110 to 120, this is intraventricular conduction delay, and anything above 120 is a wide QRS or bundle branch blocks. QT normal differs between males and females, anywhere between 450 to 470 milliseconds. This is the PR interval. Anything more than a box is first degree AV delay or AV block. This is a normal PR interval. If you measure it from the initial part of the P to the initial part of the Q, this is not more than a large box or not more than 200 milliseconds. This is a normal PR. This is an example of a long PR interval. You can see, if you measure it from here all the way to the Q, this is almost more than 2 large boxes. So we refer to that as first degree AV block. First degree AV block is a misnomer because there is no real block. All the electricity from the atria is still conducting to the ventricle. So we refer to it in electrophysiology as AV delay rather than block. Okay. The next thing is the QRS, and as I mentioned, it's between 90 to 120. I'm going to go a bit faster here. As you can see, this diagram shows you that electricity conduction through the conduction system is very fast. In the atria, it's about 0.5 meter per second. In the AV node, it slows down the electrical signal. The speed is about 0.05 meter per second. These are things to remember from your physiology. And in the bundle of His and the bundles, it's 2 meter per second. If you imagine, the conduction system is very short, and a speed of 2 meter per second. This is activating, the wavefront very quickly, and Purkinje fibers are even faster. They're 4 meter per second. And that's why, the QRS is very sharp and it's very short. Anything going through the conduction system should be sharp and should be short, unless of course, you have disease in your conduction system. So if you have disease in your bundles, if you imagine those bundles as highways, and this activation wavefront is going through the highways, and if one highway is blocked, then you're going to have slowing of the conduction system. In this example here, there is left bundle branch block, meaning that the activation started in the sinus node, traversed the AV node and the His, and when it's going down, this left bundle is blocked, activation goes down the right. Still, the left ventricle gets activated. It doesn't mean that if you have blocked, the left ventricle does not get activated. There are still muscle-to-muscle conduction and small fibers that get the activation through the left ventricle, but it's much more slower. This is just a cartoon that depicts left bundle branch block, activation wavefront. As you can see it here, it's blocked, up here, and wavefront starts by going down the right bundle, activating, the right ventricle first before it spreads to the left ventricle. And the positioning of the leads, lead V1, is really what determines that, morphology that you need just to keep in your mind about a left bundle and a right bundle. Left bundle will always give you a very negative, deep S wave in V1 with a wide QRS. Sometimes you might see a small R, but the predominant wave is negative. Right bundle branch block is the opposite, of course. Conduction system is going down the left bundle, and it's getting blocked down this right bundle here. This is the cartoon showing the same thing. I'm just gonna go a bit faster here. What determines, as I mentioned, if you have right bundle branch block or left bundle branch block is the appearance in V1. And it's mainly the terminal portion of the QRS in V1. Because sometimes you can get those QRS morphologies that you're not sure, is this left bundle or is this right bundle? You're not sure, the QRS is wide. What is gonna cut it for you is to look at the terminal portion of the QRS in V1, not the initial portion of the QRS. And if it's negative, this is left bundle branch block. If it's positive, it's right bundle branch block. And here is an example of that. So we usually look at V1, and you can see here it's all negative. But if I'm not sure, maybe there's some positive, some negative, whether I call it right bundle or left bundle, is the terminal portion or the second half of the QRS. If that is negative, this is left bundle branch block. Here you can see this is the pattern on right bundle branch block. If you look at the terminal portion of the QRS, it's positive, and the QRS is wide, wider than 120 millisecond. That pattern recognition, left bundle branch block, right bundle branch block. This is just an example of the same. The QT interval, the normal is anywhere between 450 to 470, and it varies, as I said, between females and males. Females tend to have a longer QT interval compared to males. This is how you measure the QT interval from the beginning of the Q to the terminal portion of the T. And sometimes if you have a T that is not discrete, you make a tangent line from the peak of the T wave. And the junction of that line with the isoelectric line, this is what we call isoelectric line. This point is where you measure the QT from. The QT is measured mainly from lead 5. Another lead to measure from can be lead 2, as well as AVF. This is a measurement of the QT interval here. This is an ECG here that is showing you that the QT interval is very prolonged. A very easy way to determine just by eyeballing, just looking at the ECG, if the QT is prolonged or not, is to look at the RR interval and check where half of that RR interval is. Let's say the RR interval is here. If the QT is passing that half distance of the RR interval, that tells you that the QT interval is prolonged. So, you know, a rough rule is to, instead of measuring, is to look at the RR interval, get half of the RR interval. If the QT is longer than that, then this is prolonged QT interval. If it's shorter than the RR interval, then it is not prolonged. The way we measure, as I said, is from the first part of the QRS to the terminal portion of the T. This is your QT interval. You can correct for the QT interval by using the Bazet's formula. As our heart rate slows, the QT prolongs. As our heart rate goes faster, the QT will shorten. So to correct for the heart rate variability in QT intervals, there is a formula called the Bazet's formula. It is the QT divided by the square root of the RR interval in seconds. The next thing we look at is the ST segment, and this is between, I see a couple of questions. Do you want to take those, Mazin, or shall we continue?
Sure. The questions, one of them was about junctional rhythm. And there is a question about what does prolonged QT interval mean? I'm assuming it's more of a clinical aspect.
Sure.
And
so
the last question is about digitalis effect with AV blockers. So
I see. Okay, so these are more of clinical questions, but the first question is about the QT interval and the significance of a prolonged QT interval. If you imagine the action potential that I showed you earlier on, you know, if the action potential gets prolonged, this is what causes QT prolongation. And if the QT gets prolonged, this is, you know, a substrate for arrhythmias to happen. You know, when we have prolonged QT interval, whether it's because of medications, there is a long list of medications, and there's a website that you can check for all the medications that can cause QT prolongation, and whether it's congenital. QT prolongation means that the repolarization phase of the action potential has been prolonged. Most of the time, this is due to problem in potassium channels, you know, rectifier potassium channels, whether it's congenital problem, or because of medications that block those potassium channels, it prolongs the QT interval, and this is a substrate for arrhythmias. It can cause mainly ventricular arrhythmias if you have a prolonged QT interval. The second question, Mazin, was about what? Junctional rhythm?
Junctional rhythm, yes.
Junctional rhythm. So as I mentioned, a rule to remember, whoever is faster in the electrical conduction system of the heart is the one who takes over. The fastest group of cells in the heart are the sinoatrial node cells. That's why we refer to normal rhythm as normal sinus rhythm, meaning that, you know, the origin of that rhythm is coming from the sinus node. The electrical conduction system as well have other pacemakers. It's not just the sinus node. There are pacemaker cells in the AV node, in the junction, even the ventricles. They have their own pacing, you know, ability, but it's very slow. You know, ventricular escape rhythm are, you know, they're designed to prevent us from, you know, just passing out if we have complete heart block. They, you know, they just wake up those escape pacemakers, but they're slow. So what I'm getting at, you have different places in the heart where you have pacemaking functioning cells that have the ability to automatically, fire. We call it automaticity, but the sinus node is the fastest. That's why it takes over. For example, if somebody have disease in the sinus node and the sinus node slows because somebody has scarring in the sinus node, or he have an infarct and the artery supplying the sinus node has been affected, so the sinus node is not as robust as it used to be. And let's say that the sinus node is beating about 20 beats per minute. The junction might be beating faster because the high junction, especially below the AV node, can have rates up to the 60s. So since the rule is whoever is faster will take charge, the junction will take over, and then the rhythm will be junctional. You're not going to see P waves on the ECG, but you are going to see QRSs, which are narrow and very regular, but you're not going to see P waves. And in that case, you would call this rhythm junctional rhythm. I think the effect of digitalis on the AV node, digitalis can affect the AV node in different ways. It can even affect the atria and the ventricles in different ways. It can cause all kinds of funny rhythms, from atrial arrhythmias, all degrees of AV block, to even ventricular arrhythmias. Digoxin toxicity can cause what is known as bidirectional VT. So it can cause all kinds of different rhythms. I will go through hypertrophy quickly. We're referring to hypertrophy of chambers. And here we're looking at the morphology of the P wave in the inferior leads and in lead V1 to tell us about atrial enlargement. So if the P wave is tall, and you will find those criteria in the different books that you're going to read. A normal P wave is 2 and 2.5, small boxes. If the P wave becomes taller than 3 boxes, we call it right atrial enlargement. The P wave is usually 2 boxes wide, or 2.5. So if the width exceeds that measurement, then it is left atrial enlargement. As you can see it here in this example here the P wave is wider than 2 boxes. Most of the books say 2 boxes. If you exceed 2.5 or 3, you're getting into that. Another definition of left atrial enlargement, because I told you the biphasic P wave in V1, that second component is because of left atrial enlargement. So if this is wider than 1 small box, deeper than 1 small box, this is another definition of left atrial enlargement. In the past, this used to be called P mitrale, when you see an M-shaped wide P wave, because the most common cause of left atrial enlargement back in the days was mitral stenosis. So that's why it was referred to as P mitrale. You mainly see tall P waves in patients with pulmonary hypertension, which is mainly caused by problems in the lungs or lung disease. So that's why it was referred to as P pulmonale, because of mainly lung pathology, which is causing right atrial enlargement. RVH is mainly looking at lead V1 and V2, provided that your QRS is less than 120. If your R wave, how tall this R wave in V1 and V2, if it's more than 7 millimeters, this will satisfy your criteria for right ventricular hypertrophy. For LVH, you have all those kind of criteria. I don't remember them all. What I would advise is just to remember one of them and keep it in your mind, and just use one and get used to it. I think you can read through those. Some of them will take only 1 lead. For example, AVL. If how tall your QRS in AVL, if it's more than 11 millimeter or 11 boxes. So this is 2 large boxes and 1 small box. If it's larger than that, then it is LVH. I use the combination usually of V1, V2, this deep wave here. You add all those QRSs, how deep this is to the, how tall the R waves in V5, V6. So it's actually, which criteria is this one here? It's the R plus S. Yeah. V1, V2 plus V5, V6, adding those, whichever one is taller. So here I would choose V1, and here between V5 and V6, I would choose V5 because it's taller, and I would add those. And depending on the patient's age, there is certain cutoffs. So I think just pick and choose one and try to remember it. The last thing is looking at the ST segments. And, the first sign of, ischemia is actually hyperacute T waves. The T waves become very tall. And by definition, it's taller than 7 millimeter to call a hyperacute T wave. Then they can be ST segment depression and ST segment elevations, as well as Q waves. The way you decide on ST segment depression and elevation is through your isoelectric line, or what we refer to as the T to P segment. T to P segment is what helps you decide is the ST segment elevated or depressed. There are criteria as well for calling ST segment elevation and ST segment depression. You can find it in the international definition of MI. There's a document that tells you if you have 1 millimeter ST segment depression in 2 contiguous leads, this is when you call them. ST elevation as well. If you find more than 1 millimeter ST segment elevation in 2 contiguous leads, then you call it ST elevation. The rule is a bit different for V2 and V3. The cutoff is a bit higher to 2 millimeter to 2.5, depending on gender and depending on age as well. T waves, or actually T waves, yes, if they are inverted, they have to be as well in 2 contiguous leads before calling those significant T waves, because it's common sometimes in certain leads, especially in V1 and lead 3, to find inverted T waves. So these are not abnormal. Pathological T waves is when there are 2 of them inverted in 2 contiguous leads. For Q waves, these are negative deflections, which are more than 1 small box wide, more than 1 box deep in 2 contiguous leads before you can call it, pathological Q wave. Sometimes in certain leads, you can see Q waves or a slight negative deflection. This is depending on where is the activation wavefront going to. Sometimes it goes towards the lead and rapidly goes away from it, and that causes that negative deflection. And there are a lot of differential for Q waves, including, for example, things like hypertrophic cardiomyopathy and, for example, amyloidosis and all that. This is an example of hyperacute T waves on the left side, and these are examples of ST elevations. You can see there is significant ST elevation in lead V2 all the way to V6. Here, there are example of Q waves. You can see that there is a small wide Q wave, 1 box wide, 1 box deep in 2 contiguous leads. So you can see that there's Q waves here as well. When we're referring to ST segments, you have to lump the leads. So 2, 3 AVF are called inferior leads. 1 AVL, V5 and V6 are called lateral leads. V1 and V2, they're septal. V4 and V3 to V5 are anterior. As I showed you in the diagram earlier on, imagine these leads are like cameras, and they're looking into the wavefront coming towards those leads. ST elevation and ST depression are ST axis. The ischemia has an axis, and that's why if the ischemia axis is going towards V1, V2, or V3, that will cause ST elevation in those leads, and that will tell us it will help us localize the vessel or the territory of the infarct. This is an example of ST elevation. As I mentioned, be systematic before you read the ECG. Of course, go through the rate, rhythm, axis, intervals, hypertrophy before you reach the ST segments. So here the rhythm is sinus rhythm, the rate, or if you start by the rate, you can count the number of large boxes. You can say 1, 2, 3, 4, maybe 5. This is 60 beats per minute. So you can call it sinus rhythm or sinus bradycardia because the cutoff is right away at 60. The rhythm is sinus because it's upright in 2, 3 AVF. It's upright in lead 1. And it's positive in 1, should be ideally biphasic, but it depends on the atrial size. Sometimes that's why you get a positive in lead 1. The PR interval is normal, the QRS is narrow, it's not more than 120. the QT interval, just eyeballing this. If you go through the RR interval and you go by half, the QT is falling into, the first half. That's why the QT is not prolonged. And if we're to look at the, ST segment, this is our TP line. This is your T wave, and this is the P wave if we take this lead. And ST segment is here. This is your isoelectric line. If you draw that, you will notice that there is at least 2 to 3 millimeter ST segment elevation in the inferior leads, 2, 3 AVF, and this is an inferior STEMI. Okay, Q waves we spoke about, deep waves in 2 contiguous leads. And when I'm saying contiguous leads, if you see Q waves, they should be in inferior leads. For example, if you see a Q wave in AVF and AVL, these are not contiguous leads. Contiguous means they're looking at the same wall of the heart. 1 AVL, V5, V6 are lateral. Inferior leads are 2, 3 AVF. Before you call, ST segment depressions, elevations, or Q waves, remember which camera is facing to which lead, or which part of the wall of the heart you are facing. I think I'm just gonna, conclude by just telling you to remember, just, be systematic, and for every ECG, follow those rules. Sometimes you will see something like this, where it's very obvious that there's ST elevation, but you're gonna miss that the patient is in complete heart block because you did not pay attention to the relationship between the P and the QRSs, and you did not pay attention to subtleties. One thing is gonna be shouting at your eye and you will be looking at something different. So please be systematic. Learning is repetition. Every day look at an ECG. If you have problem bleeding an ECG, feel free to email me, or email any of your colleagues who know how to read ECGs, and we can go through it. We presented a few cases or scenarios, so we can go through them. I think you've already had the PDF. This is a 45-year-old coming for annual check. So the question was, what is the correct ECG interpretation? Normal sinus rhythm, AFib, flutter, ectopic atrial rhythm, or ventricular tachycardia? So what do you guys think? So anyone who wants to take this?
Okay.
There's a question.
شباب ممكن تشاركوا معنا عن طريق الشات فانكشن او عن طريق الكيو ان اي لو في زول حاب يشارك او يجاوب على الاي كي جي فايندينج. Meanwhile, Dr. Khidir, في سؤال عن hyperacute T wave and peak T wave. Are they the same?
Hyperacute T waves and peak T waves are the same. Yes, it's just a description of how the P wave is looking. لو ال P wave عندها peak to it, this is what you call peaked or tented T wave. Hyperacute refers to being just very tall, but the peak means you just have a very tented tip to the T wave. And the reason you have hyperacute T waves is mainly because of hyperkalemia. In ischemia, the reason you get hyperacute T waves, when you have ischemia, cells die, right? We said that the main intracellular ion is potassium. So if you get ischemic, you're going to release potassium locally. That's why the first sign of ischemia is a hyperacute T wave. So
we go back to the EKG. We have some answers coming in. We have one ectopic atrial rhythm, and the other answer is normal axis and normal sinus rhythm.
Okay, so the correct answer here, I'm asking about the, whether the rhythm is sinus, AFib, flutter, ectopic atrial rhythm, or TAC. And the right answer is sinus rhythm. And as I mentioned, to determine sinus rhythm, you have to look at the P wave morphology in the inferior leads, 2, 3 AVF, lead 1, and you look as well into V1. And if it's upright in those leads, that means that the activation wavefront is going from high in the atrium towards the inferior leads, and that's why you get a positive P wave. And it's biphasic in V1, as I explained before. It's initially going towards the right atrium, and then the activation wavefront goes all the way posteriorly to activate the left atrium, and that's why it's biphasic. So here, the rhythm is originating from the sinus node. This is sinus rhythm. If we're to go systematic here, you're going to calculate the number of boxes, 1, 2, 3, 4. So these are 4. So 300 divided by 4. This is 75 beats per minute. So this is sinus rhythm at 75 beats per minute. Axis is normal because you look at V1. I'm not sure why V1 is not showing in my screen now, but V1, imagine it's upright and AVF is upright. This is normal axis. And then intervals are normal. PR interval is normal from the beginning to the beginning of the QRS. The QRS duration as well is normal. QT interval is normal. I don't see any signs of hypertrophy in the atria and not in the ventricles, and the QT interval is normal. So this way you run through your ECG. The correct answer is normal sinus rhythm, normal axis, normal intervals, normal.
Dr. Khidir?
This is the most common rhythm that you're going to encounter in your clinical practice. Okay, I think I see a question.
Yeah, ECG can be very subjective. To what extent should I depend on it?
I'm not sure what you're referring to by being subjective. I think we have criteria and you have a lot of things. So maybe there is some subjectivity in terms of, for example, if I say this P waves is 2.5 boxes and you say this is 3.5 rather than 2. But, in electrophysiology, we use calipers. We're very, electrophysiology works in milliseconds. We're very discreet about, what we describe. So there might be some subjectivity, but I think overall it's very objective, tool that you can, reach a diagnosis from quite most often. Let's go to the second one. So this is a 71-year-old presented to the ER with a stroke. And the same questions. What is the correct ECG interpretation? Normal sinus rhythm, atrial fibrillation at a heart rate of 96, atrial flutter, ectopic atrial rhythm, atrial fibrillation at a heart rate of 160 beats per minute. Any answers, Mazin?
We're just waiting for a minute. So I have the first answer coming out as A flutter.
A flutter. Okay. I think, the person who answered A flutter is mainly looking at V1 and he's looking at those, wavy, waves here. And that's why maybe he's saying, flutter.
And now I have
first of all,
with a rate of 96 as well in the answers.
Okay, good. And why did whoever mentioned that, why did you say 96 and why did you say atrial fibrillation? I think this might be easy for some of you, but we're just running through the basics today. The correct answer is atrial fibrillation, first of all, because first of all, you don't see any P waves. So I usually go to look at lead 2, 3 AVF and V1, and I don't see discrete P waves. And I see those tiny squiggly lines, which I will call fibrillatory, waves. For flutter has to have, stereotype mirror-shaped those wavy lines. As you can see, those things that you see in this part of the tracing, you don't see here. For flutter, they have to be the same seesaw up and down in almost all the leads before you call it flutter. In V1, this is coarse fibrillatory waves here. They are fine, for example, in AVF, but this is atrial fibrillation. And I think here, what the other thing I wanted you to pay attention to is what is the rate. This is an irregular heartbeat. In order to determine the rate from the ECG, I told you the ECG strip is 10 seconds. So in order to determine the rate, you're going to count the number of QRSs and multiply by 6. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. So 16 by 6, you just do the math and it will give you the beats per minute. Is there any question or shall we move?
Not so far, we shall continue.
Okay, so this is the third question, 90 years old lady with syncope. And the question was, the atrial rhythm is originating from where? From the sinus node, from an ectopic atrial focus, from a pulmonary vein, from the coronary sinus, or from the AV junction? And here I'm just trying to get to fixate on looking at the morphology. Do you notice P waves or not? So here, if we go systematic, if you go by rate, the rate is very slow. You can see if you count the number of large boxes, 300 by those large boxes, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. This is almost 30 beats per minute. Okay, is it sinus or not? What is the rhythm? You look at read P1. My question is about where is this rhythm originating? And I'm telling you that the rhythm is originating from the sinus node, because the P waves that you see, at least on these leads, these are all P waves, are upright in 2/3 AVF and almost biphasic, in V1. The amplitude is a bit low, but it's biphasic, in V1 with a negative deflection there. If somebody is relying here on telling me, well, the relationship of the P and the QRSs, I know that this rhythm is actually sinus rhythm with complete heart block. There is no relationship between the Ps and the QRSs. They're divorced from each other. The P waves are marching, the QRSs are marching, but the relationship between them tell you the relationship between the top and the bottom. My question was, where is the rhythm originating? It is originating in the sinus node. If my question was, what is the correct interpretation of the ECG, you can say, yes, this is sinus rhythm with complete heart block, with an escape rhythm in the 30s.
Most of the answers, Dr. Khidir, were AV junction.
Mm-hmm.
So I think we should just highlight it, because I think there is some.
Sure. The rhythm originating in the atria. So that was my question. So I did not say where is the ventricular rhythm originating from. I did not ask what is, so this is an exam type of technique, so you always have to read the question. I ask you, where is the atrial rhythm originating? I did not ask about where is the QRS originating. If I had asked that, where is the QRS originating, an answer might be right. It's originating from the junction, or it's originating even from the ventricles. So the atrial rhythm is originating from the atria, from the sinus node, because of the P waves. That was the question. But if I ask you about where is the QRS is originating from, I would have said they are mainly originating from the ventricle. These are ventricular escape rhythms. Ventricular escape rhythms are usually wide and very slow. Junctional escape rhythms are usually narrow and faster than 30. They're anywhere between 40 to 60 beats per minute. If it's slow and very wide, these are usually ventricular escape rhythms.
And just to highlight one thing is that commonly we see that as cardiologists is that the comment on EKG will always be complete heart block, but we forget to comment on the atrial rhythm. Always the comment is on the escape rhythm, but the atrial rhythm is not mentioned. And the proper way to do it usually, and Dr. Khidir can correct me, is to mention that the patient have complete heart block, but you have to also comment on the underlying atrial rhythm.
Excellent. Yeah, excellent point, Mazin. In electrophysiology, we always think what is the top chamber is doing and what is the bottom chamber is doing and what is the relationship between them. So you can have atrial fibrillation on top and still you can be in complete heart block. So you're not going to see P wave. Usually in atrial fibrillation, the rhythm is irregular, but in atrial fibrillation, if you see atrial fibrillation, no P waves, and you see a very regular rhythm, this is when you think that this is actually AFib with complete heart block. This is a clue that the patient is in complete heart block. So always think about what the top chamber is doing, what the bottom chamber is doing. For example, in ventricular tachycardia, one of the diagnostic tools in the Brugada criteria, some of you have heard about it, is AV dissociation. And this relies on the fact that sometimes you can see P waves, but they are dissociated from what the ventricles are doing. So this is telling you that the top chamber is actually in sinus rhythm, the bottom chamber is in VT, and they are dissociated from each other. The differential diagnosis of complete AV dissociation, one of them is complete heart block, but it's also VT. VT is another example of complete AV dissociation, but it's just a fast rhythm. All right, so let's go through the last one, 57-year-old, so that we can, finish. With ischemic heart disease presenting with palpitation, how can you describe this rhythm, or how can you interpret the ECG? Is this normal sinus rhythm, AFib, flutter, narrow complex tachycardia, or wide complex tachycardia? Any answers?
Wide complex tachycardia, Dr. Khidir, in the answer.
This is a wide complex tachycardia. I'm interested, for you to look into the QRS, and if it's more than 120 milliseconds, this is a wide rhythm. If it's less than 120, it's narrow. This is fast. If we go by, the systematic way, the rate is very fast. This is almost 150 beats per minute, right? The rhythm is not sinus. I don't see any discrete P waves. Axis here is left axis deviation. And the rhythm, the intervals here, you cannot comment, of course, on the PR interval. You can only comment on the QRS, that is wide, and it has a right bundle branch morphology in V1. So I would, interpret this rhythm as a wide complex tachycardia. I think in future sessions, we'll go through narrow complex tachycardia and wide complex tachycardia, and how can we diagnose VT versus SVT with aberrancy, and accessory pathway tachycardia with, orthodromic versus antidromic, AVRT. There are different kinds of rhythms. I think we're starting with the basics today, getting some concepts and having a systematic way of reviewing ECGs. For those who attended, I just wanted to thank you all for your time. If you have questions, please send them to Mazin or send them to me. We can be in touch by WhatsApp or email. If you have questions about ECGs, we're always here to, to help you. In future sessions, what we can do as well is bring ECGs so that we can just read it together. I think the more we read, the more you will be good at reading ECGs. Thank you, Mazin, and thank you for all of those who have been attending.
طيب نيابة عن نفسي أنا مازن عمر الأمين خالد وعن سابا مكتب الباطنية بنشكر دكتور خضر دلوك كثير على زمنه، وشكرا لكم إنكم صبرتوا معنا. الليلة زدنا عن الزمن شوية، لكن حسينا إنه المحاضرة مترابطة مع بعض، وكذا كانت طريقة كويسة إنه نقدر نربط كل الأجزاء بتاعت المحاضرة سوا، وانتهينا بإنه جاوبنا أسئلة. شكرا لكم على مشاركتكم في برامج سابا التعليمية، وممكن تشتركوا معنا في صفحتنا في الفيسبوك وقناتنا في يوتيوب اللي هي سودانيز أمريكان فيزيشنز أسوسيشن، وعندنا قناة في تليجرام. إن شاء الله حنرسل لكم عبر الواتساب وعبر التليجرام الاستبيان بتاع ما بعد المحاضرة، وإن شاء الله نشوفكم السبت الجاي في محاضرتنا الجاية. شكرا لكم جميعا.